Here we go.
Oh,
It's
there we
back
go.
on now.
Okay,
Thank you.
okay.
So welcome back from lunch. If you'll take your seats, we'll turn the podium over to both Nicole Stout, who just spoke, and also Heather Ferguson, who is the founder of the Lymphatic Advocacy Group. We're so pleased to have both of them to tell us the latest updates in legislation and health policy. And we'll go till about 1:15 and then move to the next program. Or do our best.
I keep getting my time chopped and chopped and chopped. And so I'm going to talk quickly. The good thing is, again, I'll be able to share these slides with you. I don't know if we'll do that through an ALFP site or however, but I think what I've done in the slides is embedded a lot of hyperlinks directly to the articles, the bills, the regulations, so that you can access those yourself. And I'm going to talk quickly because I want Heather to have adequate time to talk to you about the bill. And so I was asked to talk about some of the policy issues that are impacting us. And a lot of times I know we think about policy and we think about legislation, right? Federal mandates and state mandates and legislative. That's one part of policy. But I want to talk to you about some of the multiple levels of impact that we're seeing with changes in regulation, changes in accreditation around the country, because those things impact clinical practice, they impact payment, and there are a number of regulatory initiatives that are impacting our therapists on a day-to-day basis. So we'll talk about these different topic areas, some of the regulatory issues, new emerging accreditation standards that are going to have an impact on us, some of the national reports, mostly focused in cancer. And I know I keep bringing us back to cancer. It's where a lot of information rises to the top and has a direct impact on us treating a major impairment associated with cancer. Some of the professional association initiatives that we're seeing in the development of corsets and alternative payment models, and then the federal legislation. So let's first of all talk about functional limitation reporting. Our therapists are entrenched in FLR, collecting functional data on therapy services and outcomes. The goal here with CMS instituting the FLR Rule 1590 was to begin to capture information about how therapists treat patients, what their thought process is in identifying functional limitations that patients experience, categorizing patients based on severity of the condition presentation. So FLR is based on the International Classification of Function and Disability. If you understand ICF, if you understand the framework of the International Classification of Function, functional limitation reporting is easy for you. And people's chins hit the ground when I say that, because Medicare didn't just make these things up. Medicare based this coding matrix on ICF. And Medicare intends to continue to expand this coding matrix using the ICF model. So the functional limitation categories that they currently are asking therapists to report on are these. And you can understand when you're looking at your patient with lymphedema of any body part, how we can categorize difficulties in function or limitations in function that patients experience. They threw in a code called Other. And part of the reason that they did that was because they expect to see a vastly expanded code set in the future. So therapists have to document the primary functional limitation that the patient experiences out of this list. They have to document the severity of the patient's presentation using a modifier code. And they have to document how they got to that conclusion. So what tests and measures told them that the patient was very severely involved versus less severely involved. And then the therapist has to use their clinical judgment to say, in 6 visits or in 10 visits, I expect the patient to be at this point. And as they take the patient through their trajectory of care, they have to be able to capture, using outcomes measures and assessment tools, how the patient's level of function changes over time. It's a bit complex, and it's become quite a complicated issue for our therapists. Clinical assessment tools are the key here. Therapists need to use validated outcomes measures. And we talked about some of those measurement tools before, the FACT-B and the DASH and those kinds of things. Let me tell you, that's not what Medicare is looking for. They're encouraging the use of global functional measures. Things like the AMPAC score, the photo score, optimal. We may be familiar in the cancer population with the PROMIS or the CARES tool. Those global metrics are what Medicare wants, essentially, to see us move towards using. A primary functional measurement tool that encompasses the entire population. So utilizing things like a DASH or a FACT-B +4 in the future might be nice to inform your treatment plan of care, but from a reporting perspective may not be what will be necessary. There is some guideline for you, or some guidance as to what the outcomes tools that are validated in the lymphedema population. Laura Gilchrist's article that was in Physical Therapy in 2009 does a really nice job of outlining the psychometrics of a number of different tools that exist and looking at what patient populations those tools have been validated in. The ALFP has undertaken a survey to determine how therapists are using these codes and to what degree. So in 2013, we conducted a survey of lymphedema therapists and their coding practices. We had over 900 respondents, and I can't share that data with you because we have submitted it to present at the NLN conference. So hopefully once it's accepted there, we'll be able to present that and see you all at the NLN conference in September. But we did, our data collection did look at, we asked therapists about their prevalence of Medicare patients in the population, how familiar they were with using G codes, how many of them were using them in their Medicare patients, and what codes they were commonly using, and what outcomes measurement tools they were using. And I'll tell you, they're all over the place. Our fear is, and those results have been submitted, and as I said, we hope to present those. We want to repeat that survey this year to see what the change has been from baseline. I think that's going to give us more valuable data to then go forward and to help make some policy recommendations. The fear is this, and it's not just in our community of lymphedema. The fear is Medicare is going to look at these data and they're going to see such disparate use of outcomes tools, and they're going to use that as leverage to suggest moving us towards one or two succinct functional outcomes measures. In fact, that was proposed to the Therapy Association Alliance about a year and a half ago. And the PT Association and the OT and the Speech Therapy Associations have fought that initiative because one functional measurement tool is challenging. If we just say in different settings, among different patient populations, we do expect to see this coding, this functional limitation reporting coding matrix vastly expanded. Again, if you know the ICF matrix, you will welcome that expansion and have a better understanding of how to portray your patient's condition and severity. So what we need to do is work, however, on identifying, again, outcomes measurements and how they are relevant to actually portraying what we're doing with our patient population. Another area of importance in regulatory that's happening right now is the CMS meaningful use criteria. Many clinics, hospital systems are moving to electronic medical record system. This is a huge opportunity for us. It helps to enable data collection into a patient registry. It is making therapists be a little bit more savvy with electronic medical records. They're kicking and screaming and fighting because many EMR interfaces are not very user-friendly. But one of the things that we have seen emerge in the field are decision support tools for therapists in the way of advising them in best practices. So this is a place where we can have a nice impact in working together with electronic medical record companies who are implementing decision support tools. We can utilize our systematic reviews and our consensus documents to help to support those initiatives. Another regulatory initiative in coding, ImpediMed has taken the lead on developing a code for measurement of lymphedema. And you may be familiar with the Category 3 code that ImpediMed had, that was approved for bioimpedance spectroscopy. The 0239T code had been approved as a Category 3. What that means is it is an investigational code that they expect to see more emerging data created and generated to inform whether or not this code should be widely utilized and developed into a CPT code. So in 2013, actually, the AMA, the American Medical Association, did approve this as a Category 1 CPT code. And in February of this year, the RUC committee reviewed it. RUC is responsible for valuing the code and saying, if you do this procedure, it should cost this much money, and this is what you should get paid. So that happened in February of 2014. Those details will be released later this year, and that new code will be implemented after 2015. This is a game changer. This is a big tipping point, because what we've seen is with a Category 3 code, many third-party payers have said this is investigational, we won't pay for it. And now moving to Category 1, our therapists and other providers should be able to see their an increase in the reimbursement rates for utilization of spectroscopy in their measurements. And I'll throw Eric Anderson under the bus. He's back there in the back if you want more information about the code and what they anticipate. We've seen a number of steps forward in accreditation. Accreditation is important to hospitals and health systems. If you're familiar with the Joint Commission, every hospital knows what the Joint Commission is. If you're a cancer center, you're very familiar with the Commission on Cancer. The COC accredits cancer centers around the country. They've developed a standard for the provision of rehabilitation services, standard E11, and that was published in their cancer program standards for 2012. It is mandatory as of 2015 that rehabilitation services are either provided on site or by referral for a cancer center. The other thing that we're seeing mandatory for 2015 is implementation of survivorship care plans. So those two initiatives, again, present opportunities for us from a policy perspective in showing our value in helping these centers obtain and maintain their accreditation. The other tipping point that I think will impact lymphedema significantly are the new CARF standards. CARF is the Commission for the Accreditation of Rehabilitation Facilities. They are international, and they developed in 2013. They brought together an international standards advisory board on cancer rehabilitation, was convened, and we developed 35 standards for cancer rehabilitation specialty programs. So based on expert input, based on the literature and models of care, 35 standards were developed. CARF will now, as of July 1st of this year, begin certifying programs around the world as cancer rehabilitation specialty programs. You can get more information at the CARF website. Those standards went through public review, they went through field review, they went through scientific review over the course of the last 6 months of last year, and are now, they were rolled out as of January 1st, 2014. There have been over 30 inquiries worldwide to CARF of health systems and organizations declaring their intent to be reviewed for the cancer rehabilitation specialty programs. And a big part of those standards is comprehensive management for impairments related to cancer treatment. So that's throughout the trajectory of care from the point of diagnosis through palliative care. This was based on the Dietz model, which encompasses preventive services, restorative services, palliative and supportive services as well. So I do think there's, again, an opportunity here for lymphedema therapy to help to facilitate many programs who have associations with a lymphedema program, or many cancer centers have associations with the lymphedema program, and you can help to facilitate the CARF standards coming and developing an accredited body within your facility. As I said, the cancer rehab specialty program is based on the Dietz model, focusing on all 4 aspects of rehabilitation needs in this patient population. It does recognize that there's a need for rehabilitation from the point of diagnosis throughout the trajectory of cancer care, and the goal is to minimize the impact of impairments, reduce activity limitations, and maximize participation. A few reports that came out last year that I think will have an impact, could have an impact on us. The Institute of Medicine, looking at delivering affordable cancer care in the 21st century, recommendations towards improving affordability and quality of cancer care. They talked a lot about quality outcomes measures and reporting and initiatives in quality reporting. Probably a more important report was the high-quality cancer report in September of 2013. The recommendations here specifically cited, two of the top recommendations here specifically cited the need for an advanced education in your workforce to deal with patients who have cancer and cancer-related sequelae. So it's what they basically said was, we're not doing a good job of educating a workforce of clinical specialists who have specialty knowledge and expertise to manage these unique conditions associated with cancer. This is a huge opportunity for ALFP and for LANA, I believe, to demonstrate the value of our workforce and our strategies at improving the level of education in our workforce. The downside, AHRQ issued a report last year on models of survivorship care. And if we're familiar with the entire survivorship movement and the idea of a survivorship care plan template, giving a patient an overview template, model of what their care was, what side effects they could anticipate, and how they can transition from cancer care into survivorship. AHRQ basically reviewed the landscape and said survivorship care is highly specific to the institution and usual care does not exist. The goal with survivorship care planning was to get us to all do the same thing, give patients information about their cancer care so that they can move into survivorship knowing their risks for sequelae, knowing how to manage those conditions. I think of survivorship plans like unicorns. Everybody thinks they know what a unicorn looks like, but they're not really certain. They've never really seen one in real. And I like to say, if you've seen one survivorship care plan, you've seen one survivorship care plan. And I think that we can help to do a better job of collating what information should be a part of a survivorship care plan so that there's some consistency with regards to the impairment of lymphedema that we see. Just quickly, the Physical Therapy Association is working on developing, in conjunction with the Center for Medicare Services, we're working on an alternative payment model that builds on the functional limitation reporting codes, looking at a stratification of severity in our evaluation and in our treatment matrix. Much more information here on how recommendations are being made to integrate prospective surveillance and lymphedema management through the accountable care organization movements. So I want to leave time for Heather. I know I buzzed through there so quickly. There's so much more to talk about, but I want her to be able to give you an update on what's happening with the Lymphedema Treatment Act because it has been, once again, resubmitted, and she's going to give you the update on what we can do to move that forward.